So we are still in chapter 4 and we're looking at lab values. We're on page 71. So the first lab value we're reviewing is folic acid. Folic acid is also called folate. The common reference range is between 5 and 25 microgram per liter. B12 and folate are ordered for further workup of macrocytic anemia. There could be low levels of folic acid due to phenytoin and phosphenytoin, taking phenobarbital, primidone, methotrexate, sulfamethoxazole trimethoprim, and sulfasalazine. Supplement folate in women of childbearing age, and also supplement folate in alcoholism. It will be beneficial to take a look at the dietary supplements chapter. So it's the dietary supplements, natural and complementary medicine chapter. The next lab value we're going to take a look at is vitamin B12. The common reference range for vitamin B12 is greater than 200 pgs per milliliter, and a patient may have low vitamin B12 levels due to taking proton pump inhibitors, due to taking metformin, due to taking colchicine, and also they may have low vitamin B12 levels due to taking chloramphenicol. The next significant lab value we're going to focus on is going to be reticulocyte count. This one is a percentage. So the common reference range for reticulocyte count is 0.5% to 2.5%. And to review this, we can recall that the reticulocyte count measures the amount of reticulocytes, which are immature red blood cells, which are being made by the bone marrow. Reticulocyte count is elevated if there is blood loss, and we may see it appear low in untreated anemia. And let's see, in a patient that has bone marrow suppression. We also may see low reticulocyte count in folate or B12 deficiency. And we also may see low reticulocyte count due to iron deficiency. The next lab value we're going to review is the Coombs test, and we're going to look specifically at the direct Coombs test, which is an antiglobulin test. And the common reference range we would expect would be that a direct Coombs test should be negative. So this test is used in the diagnosis of hemolytic anemia when the cause is unclear. For example, if there is an immune mechanism versus another cause. And we could look further in the anemia chapter. Drugs that can cause hemolytic anemia include penicillins, cephalosporins, like if there's prolonged use in high concentrations, dapsone, isoniazid, levodopa, methyl-dopa, methylene blue, nitrofurantoin, pegloticase, primaquine, quinidine, quinine, rasburicase, rifampin, and sulfonamides. So these different medications we listed can cause hemolytic anemia. It is important to review that if the Coombs test comes out positive and a drug-induced cause is suspected, you would want to discontinue the offending drug. And again, we're looking right now in the anemia section. The last thing that we're going to look at under the heading of anemia on page 70 and 71 is going to be glucose 6-phosphate dehydrogenase, which is the G6PD. The common reference range for the G6PD, or the glucose 6-phosphate dehydrogenase, is between 5 and 14 units per gram. So the G6PD is used to determine if hemolytic anemia is due to G6PD deficiency. So red blood cell destruction with G6PD deficiency is triggered by stress, foods like fava beans, or these drugs that we're going to list. Dapsone, methylene blue, nitrofurantoin, pegloticase, primaquine, rasburicase, sulfonamides. So just to review here, we looked at white blood cells, neutrophils, bands, eosinophils, basophils, lymphocytes, monocytes in the first section on page 70. And then we looked at anemia. The components of anemia were red blood cells, hemoglobin, hematocrit, mean corpuscular volume, MCV, then there was like red blood cell distribution width, or RDW, iron, TIBC, total iron binding capacity, transferrin, TSAT, transferrin saturation, ferritin, erythropoietin, folic acid or folate, vitamin B12, reticulocyte count percentage, Coombs test, looking at hemolytic anemia, and glucose 6-phosphate dehydrogenase, G6PD. That was on pages 70 and 71. On page 69, we looked at calcium, chloride, magnesium, phosphate, PO4, potassium, sodium, bicarb, HCO3, BUN, blood urea nitrogen, serum creatinine, SCR, and AG, anion gap. Continuing on page 71, we're gonna look at some lab values under the heading of anticoagulation labs. These are included typically as part of the labs or tests which would evaluate for different aspects of clotting and are used to monitor specific drugs. So the first one is the anti-XA, or the anti-factor XA activity. Therapeutic doses of low molecular weight heparin obtain a peak anti-XA level 4 hours after a subcutaneous low molecular weight heparin dose, which would be like 1 to 2 IUs per milliliter. Unfractionated heparin obtained 6 hours after IV infusion starts and every 6 hours until therapeutic, 0.3 to 0.7 IUs per milliliter. Under the notes heading, used to draw low molecular weight heparins and unfractionated heparin. Monitoring for low molecular weight heparin is recommended in pregnancy and may be used in obesity, low body weight, pediatrics, in elderly, and renal insufficiency. And we can also look at the anticoagulation chapter. So again, monitoring for low molecular weight heparin is recommended. It's underlined in pregnancy and may be used in obese patients, in patients with low body weight, in pediatric patients, in elderly patients, and in patients with renal insufficiency. And again, refer to the anticoagulation chapter for more detailed information. So let's just read this again. So the anti-XA, or the anti-factor XA activity, therapeutic doses of low molecular weight heparin obtain a peak anti-XA level 4 hours after subcutaneous low molecular weight heparin dose, and the range is the common reference range is 1 to 2 IUs per milliliter. For unfractionated heparin, not low molecular weight heparin, we would obtain the anti-XA 6 hours after the IV infusion starts and then every 6 hours until it's therapeutic. And the common reference range is 0.3 to 0.7 IUs per ml. And again, the notes say for the low molecular weight heparin, used to monitor low molecular weight heparins and unfractionated heparin, UFH. And with the low molecular weight heparins, when you're using those, don't forget to monitor, especially monitor pregnant patients, patients who have obesity, patients with low body weight, pediatric patients, elderly patients, patients with renal insufficiency. All right. So, for the prothrombin time, or the PT/INR, the INR is the International Normalized Ratio. So the PT is 10 to 13 seconds, which varies. And the INR is less than 1.2 for those who are not on warfarin. In the notes it says that the prothrombin time /INR, the PT-INR, is used to monitor warfarin. And the INR is usually elevated in patients who have liver disease. There can be false elevations in the INR, the PT-INR lab values in patients who are taking daptomycin, orativancin, and telavancin. And again, there are many interactions which can cause fluctuations like increases or decreases in the INR. So refer to the anticoagulation chapter for detailed information. With the APTT, the activated partial thromboplastin time, also known as the PTT, the partial thromboplastin time, the common reference range for the APTT or PTT is 22 to 38 seconds. This can vary. It's called the control. If you're using unfractionated heparin, obtain this 6 hours after IV infusion would be started, and then every 6 hours until it's therapeutic. So the goal for the patient that's on unfractionated heparin, the range should be for that patient, for the APTT or PTT, their range should be, again, they're on unfractionated heparin, their range should be for the APTT or PTT 1.5 to 2.5 times the control. So under the notes, ATT or the PTT is used to monitor unfractionated heparin, and direct thrombin inhibitors like argatroban. You can also have the falsely elevated levels, which can occur just like the falsely elevated prothrombin time can occur with the orativancin and telavancin. So be careful if a patient is taking those two meds. The next lab value we're going to look at under anticoagulation labs is the activated clotting time, or ACT. Again, this is also in seconds. This one is 70 to 180 seconds, which can vary. This is used to monitor anticoagulation in the cardiac catheterization lab during percutaneous coronary intervention, PCI, and surgery. Another anticoagulation lab that's very important for clotting and monitoring is platelets, also abbreviated as PLTs. So the common reference range for platelets should be like 150,000 to 450,000 cells per millimeter cubed. Platelets have an average lifespan of 7 to 10 days. They are required for clot formation. Spontaneous bleeds can occur when platelets are less than 20,000 cells per millimeter cubed. Platelets can be low due to being on heparin, due to being on low molecular weight heparins. Platelets can also be low due to being on fondaparinux, due to being on glycoprotein 2B3A receptor antagonists, due to being on linezolid, valproic acid, chemotherapy that targets the bone marrow. There's one more anticoagulation test. It's the heparin-induced platelet antibodies. So the ELISA test first, then an SRA, serotonin release assay. So the common reference range for the heparin-induced platelet antibodies should be negative, and heparin-induced thrombocytopenia, or HIT, is suspected when platelets drop more than 50% from their baseline as a result of being treated with an unfractionated heparin, UFH, or a low molecular weight heparin, LMWH. So antibody testing is used to confirm a diagnosis of heparin-induced thrombocytopenia. If the ELISA test, ELISA, is positive, a positive SRA, serotonin release assay, is then confirmatory. And that will conclude page 71. On page 72, we're going to look at some liver and GI labs, some pancreatic enzyme labs, and some cardiovascular and respiratory labs. Eventually, we're going to get into some cholesterol labs, diabetes labs, thyroid labs, gout labs, inflammatory and autoimmune labs, HIV labs, acid, base, and hormonal labs. So we're going to go up through page 75 with charting. So we have a few more charts to review. But this will conclude page 71.